Good morning, everybody. The topic that I'm going to present today, and of course I've changed the topic, the reason being that we didn't have data, LBS data on the previous topic, that is MPP7 and biliary atresia. So we decided to go about with this topic, which has some data from our department. This is role of steroids in the management of post-Kasai Biliary Atresia. There has been a lot of data on biliary atresia, but of course, to begin with, just the introduction, the incidence of biliary atresia is 1 to 5,000 to 10,000 in the Southeast Asia, that is Taiwan and Japan, whereas in Europe and North America, it's a little higher. So the incidence is varying. Europe and North America, it is 1 in 15 to 20,000. The obstructive, not higher but lower in fact, the obstructive cholangiopathy that biliary atresia affects both intra and extrahepatic bile ducts. And the Kasai potoenterostomy, which is the surgery done for biliary atresia patient, has success rate of not more than 50% in all over the world till about a decade back, or maybe a little more. The usual success rate that is seen in biliary atresia, and the way the criteria is that if a bilirubin is less than 2 milligram per deciliter, it predicts a future success, especially with a PPV, that is positive predictive value of 95% and a negative predictive value of 74% for 5-year survival with native liver. Schneider, on the other hand, also talked about 3 months bilirubin, which is, again, he said less than 2 milligram per deciliter, and said that this could predict a survival with native liver to almost 84%. And if it is more than 2 milligram, then the survival with native liver is just 16%. So you do need medical therapy after biliary atresia surgery, that is Kasai potoenterostomy, because just a 40 to 50% success rate, whether they are successful or unsuccessful, both the groups do need medical therapy. And here we are going to talk about the main aim of the medical therapy, establishment of bile flow and jaundice clearance interval as much as we can do. So corticosteroid is one of the most important medical therapies which are being used as adjuvant therapy in this set of patients. There was a lot of studies. I will just talk about 2 of them here to begin with. Davenport in 2007 said that in an RCT of 36 patients on steroids and 31 placebo, 12 months and 74% patients on steroids vis-a-vis 65% patient on placebo improved and showed jaundice clearance. And 1 month post Kasai, low median bilirubin in steroid group was 66 versus 92 millimoles per liter in the this has to be divided by 17 in the placebo group. There was no difference in the bilirubin or in the survival with native liver at 3, 6 and 12 months. So all they found important was at 1 month only. And steroids were more effective, obviously so, in children who had received the Kasai surgery at less than 70 days of age group. Dong et al. In a similar study now studied the high-dose steroids and low-dose steroids, and they again showed that in high-dose steroid you had a jaundice clearance rate of almost 54%. So jaundice clearance at 3, 6 and 12 months or more so in the high-dose steroids, and there was, but very, very, surprisingly, they said that there was less amount of cholangitis in high-dose steroids, which is a little difficult to explain. So this was, this followed editorial by Sokol in Hepatology, where he then started explaining as how this steroid going to work here. So whether you bring down the expression of MHC class 2 or your expression of the addition molecules, as you can see them here. Sorry, can I? So the expression of the addition molecules, as you can see them here. So somebody please help me, this seems to be not working. And also the decrease in the TNF alpha, bringing down the T cell apoptosis was not bringing down, and enhancing through the CD8 T cell and the affected CD4. So this is how he explained the effect of steroids in these patients. We all know that the glucocorticoids have two receptors, alpha and beta, alpha being the main physiological mediator, and this is present in the in the cytoplasm, whereas the nuclear glucocorticoid receptor is basically a regulatory receptor. So in Japan, they looked at patients who had been receiving steroids, and they found that if you can see this histopathology, the above 2 points are the controls, whereas the lower points are both coming from the biliary atresia patients, and you can see that the expression of the glucocorticoid receptor expression was much more in the patients who were receiving treatment for biliary atresia. And if you look at this, you find the ones who are group 1 are the ones who were successful and had received prednisolone. So as the dose of prednisolone increased, the expression of the glucocorticoid receptor also increased in these patients, although it was there also in those who were unsuccessful and who had received a second surgery as well. So it was said that there was a significant positive correlation between this expression and the total dose of prednisolone. And the explanation that the authors gave was the degree of the glucocorticoid expression in the intrahepatic biliary epithelium correlated with the dose of prednisolone required to sustain bile flow after a successful Kasai. We all know Sokol mentioned, the theoretical basis of the steroid usage is the same. This was a study done in 21 biliary atresia patients by Davenport, and they looked at all the inflammatory mediators except for the adhesion molecules in the beginning. They did not find the adhesion molecules to be as high. Rest of all was high, but at 6 months, even the adhesion molecules, that is soluble intracellular adhesion molecules, were high with a poor, especially so in the patients with poor response. So if you look at this, everything seems to be higher in patients who had received OLT. Everything seems to be higher. The lower ones are all patients who were alive with native liver. So this forms a basis for the steroid. And it has been seen that the soluble intracellular adhesion molecule levels at 1 month post-Kasai predicted need for transplant. 1700 almost was the cutoff. Need for transplant at 1 year with 92% specificity and 87% sensitivity. The steroid mechanism of action: increase apical sodium independent bile acid transporters, which regulate the bile acid metabolism and reduce the bile acid production. The chlorotic effect suppresses the immune function, and represses the related inflammation gene transcription. So with this knowledge behind, most of the world, at least beyond India, they were using steroids in the management of Kasai, and the Japanese Biliary Atresia Society felt that we should try and see as to what amount of steroids are being given and what is the outcome of that. So they asked all their centers in Japan, and this was the result that they found, that the ones who were getting steroids had a better anectric survival rate. So the jaundice clearance was better in those who were getting steroids. And when you look at the dose of steroid which is best was about 20 to 30 milligram per kg. This is what they have reported. I mean, it's difficult to imagine the amount of steroids that would be once you give it to a child that age. So the survival rates of the group receiving 4 milligram per kg per day and the non-steroid group, if you see, it was 58.9% vis-a-vis 35.7%, which was just marginally significant. Round about a decade later, King's College, Davenport comes out with an RCT, single center, single surgeon, low dose versus first just controls, and then he adds on the high dose also. With the first study, he did not find much difference, but with the follow-up study of only high dose and controls, he found that there was a significant difference in the clearance of jaundice, and there was no effect on the native liver survival. As you can see it, the high dose was changing the bilirubin levels at 1 and 6 months significantly, but not having much effect on the native liver survival. All the 3 groups had almost a similar survival. This is a START trial which happened in 14 centers all over America under the banner of children. 70 subjects in each RCT arm, And the age of these children was less than 180 days, average age was 69 days. They gave high dose steroids, IV methylpred first, and then prednisolone, tapering off. Percentage of parts, the criteria for jaundice-free was percentage of bilirubin, participants with bilirubin less than 1.5. They did not find any significant improvement, and the clearance of jaundice at 6 months, which was their outcome variable, 59% versus 49%. There was a very small clinical effect which was there. So as you can see, all these three, whether it's the native liver survival, or it is the the good bile drainage, or you can say even the adverse effects due after completion of treatment, they were not significantly different. But yes, the time to a significant adverse effect while receiving treatment was definitely less in steroid, which meant that steroids were causing more of side effects, adverse side effects. So this difference was very prominently then brought out by Davenport. Davenport said that the START trial was done in 18 centers or 14 centers, whereas mine was a single center and with equal number of patients that I had produced. And the number of surgeons doing a Kasai surgery and the number of surgeries done by a single surgeon is very important in Kasai surgery. We know that in UK now it is a rule that any center doing less than 6 surgeries will not be doing Kasai surgery. So that way Davenport was right. Much more than that was that the Davenport had used children who had a median, their median age was younger, 50 days, where here it was 69 days. Similarly, this group had taken up CMV negative patients, which is very important because now we know that CMV itself is another factor which can make the Kasai surgery unsuccessful. And of course, they had also used isolated biliary atresia, which means that the BASM patients, that the biliary atresia splenic malformation patients, were excluded from here. So with this, Davenport found a significant difference between those who received steroids and those who did not receive steroids. The same was not done by the START trial I just discussed. Davenport then also reproduced the Shen meta-analysis, which was in very few with very few studies, and he says it favors steroids. Another point that Davenport brought out was that in those who had received steroids, if they were less than 45 days of age, they had a good native liver survival as against those who were more than 45 days of age. So now this was building up. There was high dose and low dose now being talked about. The same START trial, although not a very good, not very strong study, but they did look at the growth parameters of the patients who had received steroids. And this has to be mentioned as well and has to be kept in mind while we are giving steroids to these patients, is that they do tend to have growth impairment. If you can see here, even with successful Kasai, both weight Z-scores and the length Z-scores seem to be not doing as well as the placebo group. The steroid group had a lower trajectory. And it was so seen even in the head circumference in both unsuccessful and successful. So this has to be kept in mind when we are giving steroids. The growth impairment, as you can see, is much more in an unsuccessful steroid. Next comes successful steroid. So it's the steroid group who has more growth impairment. Another meta-analysis in Hong Kong, now they're talking of high dose, low dose. So high dose versus no dose, no steroids, of course a very good effect towards steroids. If you look at high dose versus low dose, again it is positively towards high dose. Now here they may talk about high dose being 10 or 4, but I think the 10 and 4 both were included in the high dose, which we can talk about later. Budesonide, another single study from Germany where they gave budesonide foam enema daily for 3 months, and compared with 81 historic controls, the survival with native liver at 2 years was 54% versus 32%. But they also saw growth retardation in some of their patients who had received steroids. This is a very good study because now they're only talking about doing the steroid therapy in type 3 biliary atresia. Type 3 biliary atresia, if you can see, has the worst prognosis. The 1 and 2 has a better prognosis. So this study was done in China, where they compared the steroid and the control group with comparable characteristics, and then they looked at the 3, 6 months, 12 months, and 24 months jaundice-free native liver, and also whether the patient had a native liver survival or not. So they did find that the jaundice-free native liver was definitely significantly better in the steroid group. But when you look at the native liver survival, in the first two, in the 3rd month and 6th month, it is not there, but it's definitely there in the 12 months and 24 months period. After adjusting for all the other covariables which are mentioned here, which are very important and they can be confounders, entering the model into logistic regression analysis, the imputation odds ratio after imputation, multiple imputation odds ratio was still 2.56. So there was a 2.5-fold chance of better jaundice-free survival in steroid group, despite after you do this multivariate analysis. In the same group, they also found that the survival with native liver was definitely better in the steroid. So now even they started coming out with some data even on better, SNL, that is survival with native liver. But overall survival was not significantly different between the two groups. Yes, they also reported more serious adverse effects in the steroid group. Second last meta-analysis comes from a Chinese group. It's largely the Chinese, the Japanese, the US group, that is by George Bizarro, and the other group is Davenport. So these are the 4 groups which are largely working in this area. So this is a Chinese group which did this meta-analysis, and when they looked at the jaundice-free rate at 6 months and at 1 year, they found them to be favoring steroids, but not at 2 years. But when you look at the native liver survival, there's not much difference as far as native liver survival is concerned with steroids, at least in this meta-analysis. George Bizarro, who up till now was only working in multi-centric trials, decided to do a single-center trial. And this time he came up with both IV antibiotics and corticosteroids, of course in high dose, methylpred and followed by prednisolone. But the protocol that they followed was that they will look at the stool color. If the stool color is more than grade 4, which means it is normal, then they allow them to get discharged on like a conventional treatment. But if the stool color was less than equal to grade 3, then depending upon the age of the child at Kasai surgery, they will, if it is more than, if it's less than 45, they straight away give IV antibiotics and corticosteroids. But if it's more than 45, they look at the liver biopsy, look at the liver inflammation, and then decide about whether you discharge or you give IV antibiotics and corticosteroids. They have given an interim result of their data, and they feel that out of the 20 who under the new protocol, 80% of these patients had bile drainage, whereas the historical controls, only 40% had a bile drainage. So the conclusion was obvious. The protocol was starting any time within the first week to almost 40 days. Of course, 40 days was just one patient. They also found that the native liver survival in those with steroid group, this was better than those with the historical controls. This is the last meta-analysis, and of course not the least. It has given you the right answers and on every aspect of giving steroids. So they looked at these outcome variables, which are at 6, 12, and 24 months, jaundice clearance, native liver survival, and incidence of cholangitis. And they have done a further subgroup analysis in terms of age at Kasai, administration method, initial dosage of steroids, and the steroid type. So if you look at jaundice clearance at 6, 12, and 24 months, it is very obvious that it is favoring steroids all over. But if you look at the jaundice at 6 months and then look at the type of study, whether it's a cohort or a RCT, even then you find that both the sets of studies are actually giving you a good favor towards steroids. Then if you look at the jaundice clearance at 6 months and then look at the age at Kasai, of course both less than 70 days as well as those above 70 days seem to be favoring steroids, but more so those who are less than 70 days are performing better. Route of steroids, if you see, the best performance is that of the IV followed by oral. The one below had also a good performance, but there was just one study there, so we cannot take that. Dose of steroid, if you see, it is a medium dose, and the medium dose is now said to be 4 milligram per kg per day for IV methylpred and 3 milligram per kg per day, 2 to 3 for prednisolone. And type of steroids, of course, methylpred and prednisolone did the best. As far as native liver survival at 6, 12, and 24 months is concerned, they seem to be doing better at 12 months and 24 months in the steroid group, but not in the early native survival. Route of steroids and type of steroids, if you say it, they follow what was seen in the jaundice clearance, that the route of steroids IV followed by oral was better, and the type of steroid methylpred and prednisolone was better. When you look at cholangitis, steroids, it's obvious that the patients who had received steroids were having more of cholangitis. So the take-home messages here are that the post-operative adjuvant steroid therapy improves proportions with jaundice-free and native liver survival, more so long-term native liver survival, better in those less than 70 days of age at Kasai potoenterostomy, best with IV route followed by oral prednisolone, that is methylpred followed by oral prednisolone, and medium dosage of both the steroids. They don't seem to be, as of now, improving the short-term native liver survival. They don't seem to be improving or in fact worsening the episodes of cholangitis, and growth impairment still is a query because there's a single study that we have seen up till now. Based on this, especially the George Bizarro's thing, we have created a new protocol here which is being followed by Dr. Anmol. His thesis, these are all his slides. So if we see a stool grade color more than 4, then we do just conventional therapy. Otherwise, if less than equal to 3, we give antibiotics and steroids. Up till now, 55 or odd cases have been taken up who are in a different age group at the Kasai surgery. You see, our median age was 79 days. We're still getting higher age group children. The median age for clearance of jaundice was 8 weeks, and 51% could clear the jaundice after Kasai. The outcome was 44% only could have a native liver survival. Cholangitis was rampant in our group who received steroids. These are all patients who had received steroids. But when you look at the age of Kasai and within this group, then you find it's the jaundice-free proportion increases to 57.2% if the child is less than 90 days. We still have very small numbers, less than 70 days, so we could not do that analysis. More than 70 days, it was still bad, 41%. Thank you.